to constrict the vessel, because to reduce the blood flow to the open site tadi, yang kawasan yang luka tadi tu, dia nak reduce the blood flow tu to reduce the bleeding. Dia akan buat vasoconstriction. Our body will trigger the vasoconstriction. That's number one. Number two, activation of platelet. So the activation of platelet, okay, this one, platelet yang warna-warna biru ni, platelet, dia akan activated, and then move to the open wound tadi tu, open wound location tadi. And then this platelet will, when they activated, they will call up the other platelet to clumping together to block the open site tadi tu. And next, number 3 is the coagulation cascade. We call it coagulation cascade. So these 3 mechanism is the common mechanism that been what we call it, that been hemostasized, that been regulated by our body when there is an open wound or any injury to the blood vessel. So wound can be open wound or closed wound. So closed wound tu yang bruise tu kan, kalau you ada rasa lebam tu, yang tu closed wound lah. Kalau you macam terpotong you punya jari sikit tu dipanggil open wound. So that is the basically how the blood clotting tu secara fisiologinya. Kenapa perlunya blood clotting tu? Okay. And then the drug. So I believe you been heard about the heparin. Okay, heparin. Aspirin. Aspirin you dah belajar kan? So aspirin you dengar dekat dalam lecture yang mana? Dekat dalam pharmaco CVS ni ada tak you dah belajar aspirin? What is the clinical use of aspirin? Clinical use of aspirin. Tak belajar lagi?
Blood thinner and painkiller. Blood
thinner and painkiller. So is it any clinical use in angina or hypertension? Ada tak digunakan aspirin ni dalam angina or hypertension? Dalam hypertension ada ke aspirin? So go back to read what is the use of aspirin in the heart disease. Okay. Next is the warfarin. So in the early years, warfarin ni digunakan sebagai racun tikus. Pada masa tu dekat Europe, pada masa tu dia terlalu banyak. Not Europe lah. Pada masa tu di US terlalu banyak tikus, jadi dia found out that warfarin ni boleh menyebabkan tikus ni akan mengalami chronic diarrhea. Chronic diarrhea, dan dia akan matilah. Ataupun disebabkan warfarin ni dia punya effect dia kepada tikus. So different metabolism compared to the human. So that's the history of the warfarin. So you can read later. So in this lecture, you need to understand, try to read, I think from the hematology book. Maybe you can borrow from your friend or from your senior. What is the mechanism of blood coagulation and also blood coagulation cascade? So blood coagulation is including the vasoconstriction, platelet activation, and also blood coagulation cascade activation. And then you need to know about the pharmacology and also the use of the vitamin K, vitamin plasma fraction and whatnot. Okay. As I mentioned just now, when there is a tissue injury, the vasoconstriction is happening. At the same time, the platelet aggregation is is already started or activated, and then the activation of intrinsic and extrinsic pathway of coagulation. Please read more on this intrinsic and extrinsic pathway of coagulation. And then this pathway is like a cascade. That's why we call it a cascade. So meaning that in order to get to B, in order to get to D, A, B and C must happen. So kalau you block the B, so D takkan berlaku. So that's why they call it cascade. So hemostasis is the terminology that used to stop the bleeding, okay, to stop the bleeding. And then from the platelet aggregation and also the blood coagulation cascade activation, it also will build up the fibrin, to build up the fibrin to make sure there is a what we call it like a net to stop the blood from came out from that particular area. Blood coagulation mechanism. So when what is happening actually when the vascular injury happen, so this will expose to the reactive subendothelial matrix proteins. So this will result the platelet adherence and activation, and this also will secrete the vasoconstrictors and platelet recruiting and activating of molecules. Thromboxane A2, okay, thromboxane A2, this produced from arachidonic acid within the platelet. So arachidonic acid within the platelet, and the platelet will be activated, and also this arachidonic acid also is a potent vasoconstriction. It also will trigger the vasoconstriction. Platelet granule secretion. Adenosine diphosphate ADP is a powerful inducer for platelet aggregation. Serotonin is a stimulates aggregation and vasoconstriction. Platelet activation includes the protein alpha-2b beta-3 integrin receptor change it conformationally bind to fibrinogen with cross-link against platelets. So this receptor placed on the surface of the platelet, okay, on the platelet. So for example, I give you have two platelet 1 and platelet 2. So platelet 1 have this receptor, and platelet 2 also have this receptor. In the event without a vascular injury, no stimulation, no exposed to the reactive subendothelial matrix protein, this receptor remain dormant. Okay, remember I have platelet number 1 and platelet 2. So in the event of vascular injury, so this will activate the platelet number 1 and platelet number 3, and this platelet number 1, number 3 will combine or will hinge together at this point, at this linkage, okay. And then in the principle of anti-platelet drug, the drug that used to prevent the aggregation or the activation of the platelet, the drug or the anti-platelet drug will block this receptor. So this receptor cannot hinge or connect with the other receptor from the other platelet. Okay. Concurrently, all these coagulation system cascades activated and stabilize the platelet flux. So all this happen at the same time. This schematic diagram show you the thrombus formation at the site of damaged vascular wall and the role of platelets and clotting factors. Platelet membrane receptors include glycoprotein, GP, glycoprotein 1A, glycoprotein 1B, binding to collagen. Binding to collagen here. GP1B, GP1B receptor, binding von Willebrand factor, and also GP1, GP2B and GP2A. This is what I'm talking about. The platelet, they akan aggregate. So this platelet activated, so they will connect together with this GP2B or 3A receptor. Okay. So this is how the platelet activated. So this diagram show you the coagulation pathway. Coagulation pathway. So this is the main event in the formation of arterial thrombus. So arterial thrombus ni maksudnya dia nak stop, dia menghasilkan blood clot lah. So dalam kes ni blood clot yang dalam penceritaan ni blood clot in the event of the wound. Kalau ada berlaku vascular injury. Okay. Tetapi dalam kegunaan drugs yang kita kita berikan kepada patient ni, for example patient yang just finish with the post-ops, selepas operation, so in some cases the doctor will prescribe the anticoagulant to prevent any emboli, any blood clot happen after the operation, because because the operation you cut the tissue, right? So it will activate all these cascade. So all these cascade will be activated, and then there is a chance for the blood clotting happening. Okay, in the event of rupture of atherosclerotic plaque in artery, so this can be divided into two, which is platelet reaction and also blood coagulation. So in the platelet reaction, I already mentioned just now, addition, activation, and then the platelet will be further aggregate with each other. Concurrently, the blood coagulation cascade also activated. So this is X. This is factor 10 converted into factor 10A, and this factor 10A are needed to convert factor 2 to thrombin. So these thrombin are needed to convert fibrinogen to fibrin, and then the combination of fibrin and platelet will do the blood clotting, will stop the bleeding. Okay, so this is the physiology pathway or the physiology schematic diagram show you how's the blood clotting or thrombus is happen. So this diagram also show you the activation platelet activation by thromboxane A2. So the thromboxane A2 is generated from the arachidonic acid. Okay, arachidonic acid. So so this thromboxane A2 will activate the thromboxane A2 receptor in the platelet. Okay, in the platelet, and then it will activate the G protein activation, and G protein activation will activate all these pathway, and then at the end of the day it will activate the GP2 or 3A. So this is important for this protein GP2B and 3A is important for the platelet to aggregate with each other. So kalau this protein have a problem or any abnormality in this protein, so the platelet cannot be aggregate. So maybe can cause the thrombocytopenia. Again, this is also about the platelet activation and also platelet aggregation. Okay. This one is the starting from the resting platelet, as I mentioned just now. In the resting platelet, the protein receptor of GP2B and GP3A is not active. So When this active, so this platelet will be aggregate with each other. The link point is here, GP2B and 3A. Next. That is the platelet activation. Now we move to the blood coagulation cascade. So blood coagulation is when the soluble fibrinogen transform into fibrin by the enzyme called thrombin. So the drug either can stop the conversion of fibrinogen into fibrin, or the drug also can inhibit the thrombin enzyme. Okay. So at each step, clotting factor zymogen and undergoes proteolysis. So it will activate it to become an active protease, or active protease is the factor 7 and factor 7 to convert factor 7 to factor 7A. Then each protease factor activate the next clotting factors in sequence. So as you can see, the keyword is a sequence or cascade is all the keyword, meaning that once you block in anywhere in this pathway, in this cascade, so sure it will block the blood clotting. So thrombin play a major role in hemostasis of a blood clotting. So thrombin allowing fibrinogen to converted to be converted into fibrin. Thrombin activate many upstream clotting factors, so it will lead more thrombin generation. Thrombin activated factor 13, factor 12. Factor 12, sorry, typo. Factor 12 is a close links between the fibrin polymer and sublethal clot. Okay. This diagram show you the what we call it, the blood coagulation. So there are two major anticoagulant drugs, heparin and warfarin. These two have a very different action. Okay, heparin acting in the blood directly activate anticoagulating factors, specifically antithrombin, which inactivate the factors enclosed in the rectangles here. Whereas warfarin acting in the liver, it inhibit the synthesis factors enclosed in the circles. Okay, meaning that heparin dia act on this lah. Heparin directly act on the anti-clotting factor, whereas for the warfarin dia akan inhibit the synthesis of the factor tu. Dia akan menghalang penghasilan factor tu. Okay, alright. So this diagram, unfortunately, you have to familiar it now because we are talking about the anticoagulant drug. So nak tak nak, you have to familiar with the blood clotting cascade. Okay, blood clotting cascade. So these are the factors, the blood clotting factors that we are talking about. Factors 1, or the other name is fibrinogen. Factor 2 is prothrombin, and so on. So get familiar with these factors. Okay. This diagram show you the coagulation cascade and the site of action of the anticoagulant drugs. So the anticoagulant drug interfere with the So as you can see here, when the tissue damage, okay, when the tissue damage, what is happen here is it will activate the factor 10 converted into factor 10A. Okay, and then this factor 10A are needed to convert the factor 2 into factor 2A, which is a thrombin. And that's this factor thrombin, we converted the factor 13, factor 13, which is need calcium ion converted into factor 13A. And then these factor 13A are needed to stabilize the fibrin, whereas the factor 2A, we call it a thrombin, are needed to convert fibrinogen to the fibrin. So go back and read what is the function of fibrin, why the fibrin is important in the blood clot. Okay. So this diagram again show you about the coagulation cascade. You guys can read by yourself. Initiation of clotting, the tissue factor 7A complex. The importance of the tissue factor 7A pathway. Tissue factor is exposed on damaged endothelium. So this complex will activate factor 10 and factor 9. Factor 10 and factor 9. And then this factor 10A with factor 5A form, the thrombinase complex on the activated surface. So these are needed to convert the prothrombin factor 2 to the thrombin factor 3. So thrombin activate clotting factor includes factor 5, factor 8, and factor 11. So thrombin generation, it is a thrombin generation application. So there are anticoagulant drug that inhibit or that accelerate the thrombin. Okay, that accelerate thrombin or bind to the thrombin. So we see about it. Okay, what is the fibrinolysis? Okay, so fibrinolysis. Okay, so at the end of the cascade is the formation of fibrin. Okay, at the end of the coagulation cascade is at the end of the fibrin. In the patient with a risk to have a blood clot, okay, so we can help to remove or to reduce the blood clotting by lyse the fibrin. So that's why they call it a fibrinolysis. So the fibrinolysis is the process of fibrin digestion by the fibrin specific protease called plasmin. So fibrinolytic system is like the coagulation system. Plasminogen is an inactive form of serine protease plasmin. In injury, endothelial cell synthesis and release tissue plasminogen activator. So it will convert plasminogen to the plasmin, and then plasmin proteolytic in digestion fibrin. So this schematic diagram represent the fibrinolytic system. Okay, from the fibrinolytic system, including the plasminogen. So the plasmin is the active fibrinolytic enzyme. So several clinical useful activators. So this plasmin is a useful activator as shown in the left in the bowl. So meaning that the plasmin is useful to convert the plasminogen into the plasmin. Okay, because this plasmin will activate the conversion of fibrinogen to the fibrin degradation product, and also to stop to increase to activate the fibrin clots. Okay, this one you can do. Now we move to the anticoagulant drug. So anticoagulant drug we have indirect thrombin inhibitor. So that's why you need to know what is the thrombin, where is the location of the thrombin in the cascade. So why the drug inhibit the thrombin. So we have indirect thrombin inhibitor, we have direct thrombin inhibitor. So under indirect thrombin inhibitor, it interact with a separate protein. We call it as a antithrombin. So increase the catalytic action of antithrombin by 1,000 fold. So this drug will increase the antithrombin effects. Will catalyze the antithrombin by 1,000 fold. Example is the unfractioned heparin, low molecular weight heparin. So low molecular heparin is the improved heparin, more specific heparin, less adverse effect of heparin compared to the unfractioned heparin. Synthetic pentasaccharide or fundaporinol. So you just remember fundaporinol. And these three drugs binds to antithrombin and enhance the inactivation of factor 10. Remember, under indirect thrombin inhibitor, these three drugs, heparin, low molecular weight heparin, and also fundaporinol, will bind to the antithrombin and it will enhance or catalyze the inactivation of factor 10A. So meaning that the factor 10 cannot be converted into factor 10A. Mechanism of action of heparin. So the when you see the word heparin in the books or in the journal, heparin refer to the unfractioned heparin. So we can call it just heparin. So this heparin will bind to the antithrombin 3 with the subsequent rapid inactivation of coagulation factor. Okay. It also inhibit serine protease. So this it will it's most important that it will inhibit the conversion of factor 2 to factor 2A and factor 10 to factor 10A. So without heparin, the antithrombin 3 interact very slowly with the factor 2A and factor 10A. Pharmacokinetic, so the heparin given parenterally, IV or deep subcut administration. Therapeutic use of the heparin to expansion of thrombi by inhibiting fibrin formation, as a major antithrombic drug for acute deep thrombosis and pulmonary embolism as a prevention, used as a prophylactically to prevent post-operative venous thrombosis, as I mentioned just now. Post-operative to prevent the post-operative venous thrombosis. So heparin is one of the options to prevent the post-operative venous thrombosis. Coronary artery rethrombosis after thrombolytic treatment is also can be reduced by using the heparin. Adverse effect. So as a common sense, if you give the anticoagulant, so the adverse effect is excessive bleeding lah. Excessive bleeding. So you need to monitor the bleeding time of the patient. Okay. If the patient are given the heparin. Hypersensitivity reaction, allergic, thrombosis, thrombocytopenia, contraindication of the heparin is to the hypersensitive patient. If the patient have a bleeding disorder, so if you give the heparin, have to give it with caution or change to the another drug. That's about the heparin. Now we move to the low molecular weight heparin, LMWH. It is a fraction of heparin. So the took the main heparin tadi tu, they try to improvise it. To make sure it has better affinity towards antithrombin 3 and better action to inactivate factor 10A. But this low molecular weight heparin do not avidly bind to the thrombin. So it's given subcutaneously. So it's not necessarily to obtain the PTT index. So PTT index, you need to you learn already in the PBL. So because this drug is quite specific, so if compared to the patient receiving the heparin, this one you don't really need to monitor the patient's PTT level, PTT time, because this heparin is more specific and not really bind strongly with the antithrombin. Okay, similar if the adverse effect similar to heparin except for the thromboembolic problem. So this is the less common. Okay. Next, we are talking about the fondaparinux. Fondaparinux used as a prophylaxis in the deep vein thrombosis that can lead to the pulmonary embolism in patient with hip fracture surgery or hip replacement surgery or knee replacement surgery. So fondaparinux is an option for the post-operative patient. So this fondaparinux usually used conjunction with the warfarin for the treatment of acute pulmonary embolism and acute deep vein thrombosis. Fondaparinux selectively inhibit only factor 10A, and this fondaparinux binds to antithrombin 3 given subcutaneously. And fondaparinux also do need less monitoring compared to the heparin. Okay. So this schematic diagram show you the action of the heparin. So the heparin accelerate inactivation of coagulation factor by antithrombin. So this is the antithrombin. So antithrombin physiologically can inactivate the coagulation factor, but slow. In the presence of heparin, this heparin bind to the antithrombin. It will accelerate. 1,000 folds to inactivate the coagulation factor. So the result of the inactivation of coagulation factor, so it will stop the blood coagulation, or it will prevent the blood coagulation. And then after the antithrombin and heparin complex inactivated the coagulation factor, the heparin will dissociate from the antithrombin. And then this heparin will bind to the other antithrombin to inactivate the other coagulation factors. Comparing the heparin and also low molecular weight heparin. So this heparin bind to the antithrombin, and then this antithrombin and heparin complex will bind to the factor 10A and also thrombin. So this heparin will inactivate the factor 10A, factor 10A and also thrombin. Okay, but for the low molecular weight heparin, bind to the antithrombin. So this antithrombin and low molecular weight heparin complex will only specifically bind to the 10A. So that's why the monitoring is less in the low molecular weight treatment, because this is more specific to the factor 10A. Because and then the heparin will bind to the thrombin and also the 10A. That's why need the monitoring of the patient if the patient receiving the heparin. Okay, that is the difference between heparin and also low molecular weight heparin. This diagram also show you the differences, the action, the different action between the low molecular weight heparin and also the heparin. Next, under the anticoagulant drug is the direct thrombin inhibitor. So these three drugs, lipirudin, agratroban, and dabigatran, will bind to the active site of thrombin. So this will inhibit the thrombin effect. Okay, this will inhibit the thrombin effect. Lepirudin is a recombinant from the hirudin. It's a specific irreversible thrombin inhibitor from a medicinal leech saliva. So leech ni lintah kan. So you guys familiar with the leech? Even leech is used in some of the diabetes mellitus patient. They try to what we call it, to lyse the fibrin, to lyse the fibrin. So the saliva from the leech is modified and become a lipirudin. So lipirudin binds to binds to the thrombin molecule. So it will trigger or activate the thrombogenic activity of the thrombin block. And this lipirudin has a little effect, less effect on the platelet. Adverse effect, bleeding, of course, is the adverse effect of the patient. And this lipirudin may produce worse situation if administered together streptokinase and afterplace. So it is important to monitor the PTT and renal function of the patient if the patient receives the lipirudin. Next is agratroban. It's a synthesis molecule that inhibit thrombin, used as a prophylactically for the treatment of thrombosis in patient with heparin-induced thrombocytopenia. So the agratroban is given to prevent the patient to have a thrombocytopenia, okay, due to the heparin consumption. Agratroban also need a PTT monitoring. Patient's hemoglobin and hematocrit monitoring is also required, because the adverse effect of this agratroban is the bleeding as well. So dabigatran is a prodrug. It's a prodrug. It's used to prevent stroke and systemic embolism in patient with atrial fibrillation. So this drug, dabigatran, doesn't require routine monitoring and has a few drug interaction compared to warfarin. Okay. Next group, we have indirect thrombin inhibitor. We have direct thrombin inhibitor. Group number 3 is oral direct factors 10A inhibitor. So this drug inhibit factor 10A directly, and then is given a fixed dose and doesn't require monitoring, because this drug is specific, inhibit factor 10A only. Example, rivaroxaban. So to prevent the venous thromboembolism following hip or knee injury, not knee injury. Apixaban, still under clinical development to prevent venous thromboembolism. So you get familiar with the rivaroxaban. Warfarin and other coumarin anticoagulant. So when we talk about anticoagulant, warfarin is the first drug being developed by the University Wisconsin chemist. He's a chemist. So this warfarin derived from the coumarin compound. Okay. Warfarin stand for Wisconsin Alumni Research Foundation. Initially used as the rodenticide. In 1950, warfarin under brand Comodine was introduced as antithrombic agent in human. Okay. Generally administered as a sodium salt and has 100% bioavailability. So as you can see, it has a 100% bioavailability. So can you imagine the side effects? This warfarin is an antagonist the cofactor function of vitamin K. So it is a vitamin K antagonist. So vitamin K are needed. Vitamin K are needed to produce the anticoagulant factors. Okay, later we will see what are the anticoagulant factors produced or converted by the vitamin K. Mechanism of warfarin, mechanism of action. Factor 2, factor 7, factor 9, factor 10 required vitamin K as a cofactor for their synthesis by the liver. This is what I mentioned just now. So these factors undergoes vitamin K dependent post-translational modification. Number of their glutamic residue are carboxylate to form gamma carboxyglutamic acid residue. The reduce of vitamin K cofactor is converted into vitamin K apocyte during reaction. So this vitamin K are needed to produce or to synthesize the factor 2, factor 7, factor 9 and factor 10. So if the warfarin inhibit the vitamin K, so this synthesis of factor 2, factor 7, factor 9 and factor 10 also will be disturbed lah, akan terganggu. So apa yang akan berlaku? The blood cannot clot. Okay, the blood cannot clot because this factor is disturbed. So this diagram show you the mechanism of action of warfarin. Okay. So why the warfarin used as an anticoagulant? So as you know, as I mentioned just now, the vitamin K are needed to synthesis the factor 2, the clotting factor 2, clotting factor 7, clotting factor 9, and factor 10. So in the event to stop the blood clot, so the warfarin can inhibit the vitamin K. Okay, so the clotting factors cannot be synthesized, so it will reduce the blood clotting event, or it can stop the blood clotting event. Okay, that is the mechanism of action of warfarin. Okay. The therapeutic use of warfarin to prevent the progression of recurrent acute deep vein thrombosis and pulmonary embolism after initial heparin treatment. To prevent venous thromboembolism, used as a prophylactic for the acute myocardial infection, prosthetic heart valve, and chronic arterial fibrillation. But the monitoring are needed if the patient use the warfarin. And warfarin is readily cross the placenta barrier, so it must be used with caution if the patient is a pregnant lady. Okay. Unfortunately, the warfarin has a narrow therapeutic index. So it is important to monitor the patient INR within the optimal range. Okay. So please find out what is INR. Okay. Warfarin catalyzed by the CYP450 system into an active metabolism product. So it's not going to have a free drug accumulation, free active metabolite accumulation, because the metabolite of the warfarin metabolism is the inactive metabolites. Adverse effect of warfarin: bleeding disorder, drug interaction. Okay, I think you learned last semester what are the drugs that have interaction with the warfarin. Disease states, if the patient have the vitamin K deficiency, it will worsen the condition. Contraindication, no given to the pregnancy mother. Has a teratogenic effects, and also can cause abortion as well as the birth defect to the pregnancy. So this diagram show you the effect of anticoagulant, the affecting drugs affecting what drug affecting the anticoagulant effect in the warfarin. So, for example, warfarin will interact with the alcohol, amiodarone, proconazole, metronidazole. So these are the drugs that can interact with the warfarin. Okay. So the majors, so this is the summary of the anticoagulant drugs. The major side effect of all anticoagulant is the hemorrhage. So easy lah. So in order to prevent or to reduce the risk of hemorrhage, we need to do the monitoring, INR monitoring or PTT monitoring in the patient receiving anticoagulant drug. Now we move to fibrinolytic and thrombolytic drug. So from the name, the drug used to lyse the fibrin and thromboembolize. Okay. So this drug under fibrinolytic group rapidly lyse thrombi by catalyzing the formation of serine protease plasmin from plasminogen. Okay, plasminogen. So this drug administered IV and create a generalized lytic state as a protective hemostatic thrombi and target thromboembolism are broken down. So this basically the drug will lyse the fibrin and also the thrombi. Example, streptokinase cause a systemic fibrinolytic state will lead to the bleeding problem. Urokinase and also alteplase. So urokinase directly convert plasminogen into plasmin. Alteplase act more locally on the thrombotic fibrin to produce fibrinolysis. Mechanism of action of these three drugs, those drugs directly or indirectly convert plasminogen into plasmin. So to cleave the fibrin, thus lysing the thrombi. The therapy is effective if initiated early after the clot formation. If the clots become older, the clot is already there for a quite long time. So these fibrinolytic drugs are not useful to lyse the clot formation. So prevent to use with the aspirin and also heparin. So this is the mechanism of action of the urokinase, streptokinase, and also alteplase. So these three drugs will accelerate the plasminogen conversion into a plasmin, and degrade this plasmin will degrade the fibrin into the fibrin degradation product. So why we need to degrade the fibrin? Because when there is a blood clot, meaning the fibrin is also been formed, telah terbentuk ni fibrin. Jadi fibrin is like a net lah, it's like a net to stop the red blood cell to move. So by lyse the fibrin, so it will reduce the blood clot and improve the blood flow. That is the mechanism of action of alteplase, streptokinase, and also urokinase. Therapeutic use of this fibrinolytic drug are used to treat the deep vein thrombosis and serious pulmonary embolism. Okay, try to find the definition and the principle of deep vein thrombosis and pulmonary embolism. But now the use of these fibrinolytic drugs used to treat these two are less, because there are other alternative drug that has less adverse effect compared to the fibrinolytic drug. So these drugs, fibrinolytic drug, that have a tendency to cause a bleeding, also blunted their use in acute myocardial infarction or peripheral arterial thrombosis condition. So helpful in restoring catheter and shunt function by lyse the clotting causing occlusion. So usually, if the patient have a long-term catheter stay in the body, so this drug is useful to lyse the clot at that particular area. Hemorrhage is a major side effect of the fibrinolytic drug. Okay, this one I already mentioned just now, alteplase. Alteplase has the low affinity for the free plasminogen in the plasma, but rapidly activate plasminogen in the that is bound to fibrin in the thrombus. Okay. In contrast with streptokinase, which act on the free plasminogen and induce general fibrinolytic state. So that's the difference. Streptokinase has no enzymatic activity, but this active enzyme but form an active one-to-one complex with plasminogen. So meaning that the plasminogen, the streptokinase will bind to the plasminogen, and then this active enzyme, this complex will convert into the plasmin. Okay. The therapeutic use of the streptokinase used in acute pulmonary embolism, deep vein thrombosis, and acute myocardial infarction. Streptokinase is given 4 hours of the myocardial infarction and infused for 1 hour. Adverse effect, bleeding disorder, and also hypersensitivity. So this diagram show you the mechanism action of streptokinase. Okay. Streptokinase bind to the plasminogen to form the plasminogen complex and convert it into the plasmin, and then activate the fibrinolysis. Urokinase directly cleaves the arginine-valine bond of plasminogen to produce active plasmin. So yang ni different lah. Tadi tu before this the streptokinase bind to the plasminogen, whereas for the urokinase directly cleave the arginine-valine bond of the plasminogen to produce the active plasmin. That's the different mechanism of action of the urokinase, streptokinase, and also alteplase. So this diagram, this table show you the summary of the thrombolytic drugs. Anticoagulant and antiplatelet drug are administered to prevent the formation of extension of clots. Thrombolytic drug are used to lyse already formed clots. So maknanya kalau clots tu tak form lagi, so this thrombolytic drug is unuseful lah, tidak function lah kalau drug ni diberikan. So basically to prevent the formation of clot, we are giving the anticoagulant or antiplatelet first. And then if there is a clots, then the thrombolytic drug is useful to lyse the clots. Okay, last but not least is the antiplatelet drug. So this diagram show you where is the antiplatelet drug act on which cascade, on which cascade here. So we have many antiplatelet drug. So the principle of the antiplatelet drug or antiplatelet agent to decrease the formation of platelet-rich clots or decrease the action of chemical signal to promote the platelet aggregation. So either it decrease the formation of platelet aggregation or stop the signal in the platelet aggregation cascade. Example, aspirin, ticlopidine, clopidogrel, prasugrel, dipyridamole, efzimumab, eftilfidamide, and tirofiban. Unfortunately, you have to know all these 8 drugs. Okay, at least seven of the drug you need to remember and understand the mechanism of action. Aspirin. So thrombin, collagen, and ADP stimulated platelet. So that is the component in the platelet aggregation or platelet stimulation. So the activation of platelet membrane phospholipids that release the arachidonic acid AA from membrane phospholipid. So the arachidonic acid is released, is one of the cytokine or the chemokines that we call it, that activate the platelet aggregation. So the arachidonic acid will first converted to the prostaglandin H2 by the enzyme COX-1, and then prostaglandin H2 is further metabolized to the thromboxane A2, which release into the plasma. Okay, so this thromboxane A2 will further promote the clumping process of the platelet for hemostatic plaque formation. So this thromboxane A2 actually activate the receptor, receptor 2A, 2B and 3A just now, the receptor at the surface of the platelet. So the aspirin inhibit this thromboxane A2 synthesis, okay, from the arachidonic platelet. So actually the arachidonic acid is produced internally by the platelet itself, okay, to produce the thromboxane, and this thromboxane will activate the receptor, the receptor 2A, 2B and 3A. Aspirin used as a prophylactic treatment of transient cerebral ischemia and to reduce mortality in pre and post myocardial infarction patients. Aspirin will prolong the bleeding time. Okay, aspirin will prolong the bleeding time. So aspirin frequently used with a combination of anti-clotting drug, for example, heparin or clopidogrel. Using aspirin together with the non-steroidal anti-inflammatory drug such as ibuprofen may competing the catalytic site with the aspirin for the COX-1 inhibitor. This diagram show the aspirin inhibit, how the aspirin inhibit the platelet COX-1 inhibitor. So when the platelet been activated due to the vascular injury, so the arachidonic acid will produce the prostaglandin H2 with help of the cyclooxygenase 1 enzyme COX-1. So this aspirin will block this cyclooxygenase 1 enzyme. So no production of prostaglandin H2, no production of prostaglandin H2, no production of thromboxane A2. So no production of thromboxane A2, no activation to the platelet to link together at the protein 2A and 2B and 3A for the platelet aggregation. So that's how the aspirin works. Ticlopidine, clopidogrel, and prasugrel is sharing the same mechanism of action. It irreversibly inhibit the binding of ADP to its receptor on platelet. Okay. Adverse effect of these three drugs can cause prolonged bleeding. Ticlopidine can cause neutropenia, thrombocytopenia purpura, and aplastic anemia and aplastic leukemia. So when given the ticlopidine, so the blood monitoring is required. So this diagram show you the mechanism of action of the ticlopidine, clopidogrel, prasugrel. Okay. This ticlopidine, clopidogrel, and prasugrel inhibit the ADP-mediated platelet aggregation. So this ADP been inhibit, so there is no activation of the other platelet. Okay, the activation of the other platelet. In the presence of the ADP will activate or will stimulate the platelet, and then in the platelet there is a releasing of the increase the influx of calcium ion into the platelet, and then the calcium ion will activate the GP glycoprotein 2B and 3A receptor for the platelet aggregation. So by inhibiting the signal, the ADP signal, so the activation is not going to happen, and there is no signal, no activation. So the platelet cannot link together or cannot aggregate with other platelet. Okay, this diagram show you the mechanism of action of ifezimab, eftifibatib, and tirofiban. So this drug block the link of glycoprotein 2B and 3A. Okay, so this drug, they be a substrate. They can be a substrate to this linkage. To this linkage. So it will block the receptor GP2B and 3A to link together. So no platelet aggregation. Dipyridamole used as a prophylactic to treat angina pectoris. So this drug usually given together with aspirin and warfarin. It increased the level of CAMP by inhibiting the cyclic nucleotide phosphodiesterase, resulting in decreased thromboxane A2 synthesis. So again, thromboxane A2 synthesis in the picture. Alright. So I already explained about the eftilagimab and this program. Okay, we are come to the end of my lecture. So this table summarize the antiplatelet agent, antiplatelet agent with the adverse effect, with the drug interaction, and what are the monitoring parameters are needed if the patient receive the antiplatelet drugs. And last but not least, this is the diagram show you how the anticoagulants, antiplatelet, antifibrinolytic agents, and fibrinolytics agent works in the in the coagulation and also platelet pathway. Okay, remember in this lecture you have to know about the platelet or the hemostasis. You need to know about the hemostasis, how to stop the bleeding. Okay, how to stop the bleeding by that the physiology. That's the physiology knowledge you need to emphasize. You need to know. Okay, you need to know the platelet aggregation. You need to know the coagulation cascade, blood coagulation cascade. Why you need to know that? Because those anticoagulant and antiplatelet drug are used to stop, to inhibit somewhere in the antiplatelet cascade, in the platelet formation cascade or blood coagulation cascade. Okay. All right. That's all from me. This one is additional information for you to know. So this diagram show you the drug used to treat the bleeding. Okay. As I mentioned just now, antiplatelet drug and anticoagulant drug, the adverse effect is bleeding. Kan? Bleeding. Jadi, we need we so-called antidote. We so-called antidote to stop the bleeding. Okay. So this drug used to treat the adverse effect, the bleeding caused by the heparin. For example, we give the protamine sulfate. So protamine sulfate is given to the patient who has bleeding adverse effect due to the heparin. Okay, warfarin, we are given the vitamin K1. Okay, warfarin, as you remember just now, warfarin stop the production of the factor 2, factor 7, factor 9, and factor 10. So by giving the vitamin K, it will increase the production of this coagulated factor, so it will reduce the bleeding effect. Okay. So this is another additional info for you guys. Drug used to treat anemia, erythropoietin, iron, vitamin B12, epoetin alpha. This is a new drug, and also a folic acid. Okay, that's all for me. Any question so far? Sorry to take your time. Doctor is the antidote given with the anticoagulant drug after that. If the patient show the adverse effect, kalau patient tu tak ada tunjukkan adverse effect, that's why the blood monitoring is important. If you give the anticoagulant or antiplatelet, you need to do the blood monitoring, either INR or PTT. Okay, go back and read what is the drug monitoring. Later you will learn in the hematology class module, I think next semester. But just for fun reading, you can read what is the blood monitoring are needed when the patient are given the antiplatelet or anticoagulant drugs. Okay, if there is no question, that's all from me. Thank you for listening. I already upload the